the association of different signs and symptoms and why do they occur in polycythemia vera. So before that, basically polycythemia vera is included in an umbrella term which is MPN or myeloproliferative neoplasia. What is MPN? It is the clonal proliferation of multipotent stem cells. Those cells which have the ability to differentiate into RBCs, WBCs, and platelets. They are mutated and result due to which there is increase in the cell lines, which could be either one or more than one. These types include chronic myeloid leukemia, which we know is increase in the granulocytic precursors, polycythemia vera, which is mainly increase in the red cell line, but it can also have increased TLC and platelets. Then we have essential thrombocytosis, in which selectively platelet counts are increased. And then ultimately we have this primary myelofibrosis, which you can say is the spent phase, because the bone marrow may develop ultimately fibrosis as all the hemopoietic cells are replaced by fibrous tissue. And all these other subtypes can transform into myelofibrosis as well. So today we will concentrate only on polycythemia vera. Before that, this is a slide which I shared earlier with you people. And you can see that poly is more than one. Cythemia is the presence of blood cells. So increase in the blood cells. It could be either relative or absolute. The difference between the two is when there is relative increase in cells, it means that the other component of blood, which is plasma, is reduced. And hence it appears that red cells or other blood cells are increased. And low plasma volume is associated with number of conditions like dehydration, burns, acute volume loss, and all severe diarrhea. They can all give rise to relative polycythemia. In absolute polycythemia, it could be primary or idiopathic, where the cause is most of the time there is no cause behind it, and it could be secondary. We know that the normal mechanism of red cell production involves the presence of hypoxia, which is because of decreased RBCs or anemia. So the number of red cells are reduced, causing hypoxia, and this low oxygenated condition causes the release of a hormone called erythropoietin from the adrenals of the kidneys. And once they are released, they enter the bone marrow, where they affect the precursor cells of the erythroid progenitor lines, causing increased proliferation and production of red cells. So this is the normal feedback mechanism. In secondary absolute polycythemia, there is erythropoietin secretion, which is either appropriate, that is responding to normal hypoxia, or it could be excess production due to some erythropoietin secreting tumors. However, in primary absolute polycythemia, what happens is that due to certain mutation, the production of red cells, they become independent of the effect of erythropoietin. So excess cells are being produced without an increase in the erythropoietin secretion. Right, so this is the etiopathogenesis of polycythemia vera. We know that the normal mechanism is that this is the cell membrane over which there are certain receptors present, and they are connected through the membrane, these glycoproteins, which are mainly signal pathways. and there are receptors here as well. What happens is that usually these receptors are closed, but whenever there is a need for cell production, they open up. A cytokine or a growth factor or erythropoietin in case of polycythemia, it attaches to these receptors and it causes the activation of the JAK-STAT pathway. And this activation occurs by phosphorylation or attachment of a phosphate molecule which causes further activation of the signal pathways. So this is a normal mechanism which comes into play whenever there is anemia or a need for increased white cell production or increased platelet production. What happens in JAK2 mutation polycythemia vera is that these JAK2 receptors, they get mutated, due to which without the addition of a cytokine or a growth factor, there is excess phosphate attachment and there is increased signal messages are sent to different signal pathways. Most common is JAK-STAT pathway, and it causes increased cell survival and proliferation without the aid of any cytokine, right? So in other words, it is a gain of function mutation because the normal function is to produce cells, and because of this particular mutation, the production or the functional activity is enhanced without the effect of erythropoietin. This results in increased production of well-differentiated and functionally active cells, which are red cells, WBCs, and platelets. So ultimately what happens is that overall the red cell mass increases along with an increase in the blood viscosity. We know that normally plasma is there, which contains plasma proteins, and the purpose of plasma is to make sure that the blood flow through blood continues to flow through our veins and arteries. To maintain the normal blood flow, we need a thinner or a diluted fluid, which is the plasma. But what happens when the red cell production is increased, there is decrease in the plasma and blood becomes more viscous. Basically, it is a disease of the old age with a male predominance. So what are the common signs and symptoms, right? Most common because of excess red cell production. The excuse me, the skin complexion changes to red. Okay? So there is facial plethora. Plethora is overall a ruddy complexion or redness of the face. The conjunctiva also becomes suffused because the conjunctival vessels are engorged with blood. Okay? In all sorts of myeloproliferative neoplasia, there is extramedullary hematopoiesis. So there is splenomegaly, which is seen in almost 70% of the patients with polycythemia vera, and sometimes they may have an enlarged liver as well. The other complication or symptom that I've mentioned earlier is increase in the viscosity of the blood or hyperviscosity. It results in headache, confusion, and blurred vision. Why is there blurred vision? Because the retinal blood vessels are engorged. Since they are thin, they tend to rupture and there is collection of blood or hematoma within the retina, thus due to which the vision becomes blurred. Then gout. We know that as the red cell turnover is high, there is increased production of purine, pyrimidine, and which results in increased uric acid production, giving rise to gout, and especially affecting the big toe of the feet. So these are some of the common manifestations of polycythemia vera. This is a very interesting chart that I came across. It tells you about the pathophysiology and ultimately the explains the symptoms which are associated with the whole mechanism of polycythemia vera. So initially there is JAK2 mutation, and it has been noted in almost 95% of the cases they are positive for this particular mutation. As a result of this mutation, the erythroid cell lines in the bone marrow, they become hypersensitive to erythropoietin. That is, even small quantities of erythropoietin tends to produce a larger response. Okay. So in these patients, what we see is that there is hyperplasia of the erythroid lineage in the presence of a low erythropoietin level. So when we go for a bone marrow biopsy, we get a hypercellular bone marrow involving all the three cell lines. So this excess production of red cells makes the blood viscous, and the number of increased RBCs, they ultimately make the skin appear reddish because the blood flow to the cutaneous tissue is increased. Hence, plethora or a red face is a common feature. Then, because of extramedullary hemopoiesis, there is splenomegaly. Increased red cell turnover causes breakdown of older cells, which release increased uric acid, and ultimately they are accumulated and precipitated in joint spaces, causing gout. Similarly, hyperviscosity is associated with reduced blood supply to the brain, causing repeated headaches and spells of dizziness. Retinal blood flow becomes abnormal and may cause rupture of the retinal vessels, and visual disturbances occur. Since blood flow is reduced, the platelets, they get more time to come in contact with the endothelium, and this stagnant blood flow predisposes to thromboembolic disorders. Please keep in mind that these patients are already around 60 or more. So by this time, they have developed other comorbidities as well. So it makes them more prone to thrombosis, causing stroke or peripheral gangrene, MI, or even blockade of vessels in the arms or legs, that is DVT. So these are some of the mechanisms which is associated with increased RBC production. We know that not only red cell production is increased, but in some cases, rather in most cases, WBC count and platelet count are also increased. And what happens is that because of increase in basophils and other mast cell production, there is release of histamine in the subcutaneous tissue, and it causes severe itching in these patients. Another mechanism associated with histamine release in the stomach is that it causes erosion of the lining and may result in peptic ulceration in these patients. And sometimes when the lining is eroded, it can give rise to bleeding manifestations too. So these are the mechanisms which are responsible for all these symptoms and signs which we see in patients of polycythemia vera. This is another slide in which they have grouped together the different mechanisms and their associated symptoms. Histamine and cytokine release cause itching, night sweats or constitutional symptoms, sweating, night sweats, and bone pains. Increased red cell mass results in hyperviscosity and all those symptoms associated with it. And extramedullary hemopoiesis results in enlarged spleen or liver, and which presses on the stomach. So these patients, they suffer from early satiety, and they also complain of dragging abdominal discomfort and pain. And in some cases, they may develop weight loss as well because they are unable to eat properly. So these are the three major mechanisms which are responsible for these different signs and symptoms we come across in patients of polycythemia vera. So the current WHO classification uses this diagnostic criteria to diagnose a patient with polycythemia vera. The patient should have an elevated hemoglobin concentration with respect to the gender, or an elevated hematocrit, again with respect to the gender, or increased red cell mass. We usually don't go for these red cell mass studies because it's a tedious procedure and is no longer done over here. So we usually monitor these patients with increased hemoglobin or hematocrit. Then bone marrow biopsy is a major criteria because it shows increased cellularity of all the three cell lines, which is called panmyelosis, and with mature-looking megakaryocytes. Okay, so as compared to age, the overall cellularity is increased. Then JAK2 mutation should be present, and as I mentioned before, it is seen in 95% of patients. So if all these three criteria are met, or first two criteria with one minor criteria, which is, excuse me, which is subnormal serum erythropoietin level. This is very important because, you know, if erythropoietin level is increased, it means that it is not primary polycythemia vera. It is most likely either due to absolute increase in red cell mass because of appropriate or inappropriate erythropoietin secretion. So you need to have a less than normal erythropoietin levels. So either all the three major criteria should be fulfilled, or first two criteria along with one minor criteria needs to be fulfilled before we label a patient as a case of polycythemia vera. So this was all about the different signs and symptoms and their pathophysiology, how do they occur, and how we diagnose a patient based on WHO classification. If you have any queries, then